We will start the ligamentous injuries of the knee. That is, as you know, the anatomy, it is really a big joint, largest joint in our body, the knee joint. It is a uniaxial joint. Movement is only flexion and extension. Even though it is flexion and extension, and it is more powerful, strong joint surrounded with powerful muscles, longer, stronger and stouter muscles, and also enormous ligaments and meniscus and other structures inside the knee joint. It is more vulnerable for injuries because of its anatomical position, because it is in the lower limb, anatomical position, and very near to the earth, Mother Earth. And also, it is more vulnerable for injury during sports. Whenever there are contact sports like rugby, American football, or even in our country, kabaddi, or ice skating, and so many other contact sports. And apart from these sports injuries, sometimes the road traffic accident also, that is the violent road traffic accident may also produce ligamentous injuries. So it is a very disaster injury. Even though it is ligamentous injury, these injuries are sometimes under-diagnosed and under-treated, because it is only a ligamentous injury. There is no fracture in the bone. So we need not take it as a serious done, and actually it helps as a leverage, while extension of the knee joint, it helps to extend the knee with ease, so that it acts as a lever. And the femoral condyles, two femoral condyles, medial and lateral femoral condyle, actually it is more round in the inside the joint, and also more projected posteriorly, and it is articulating with the meniscus in the tibial plateau. As you know, tibial plateau is the upper part, and it is the superior surface of the tibia, having meniscus and anterior and posterior cruciate ligaments, and also other structures. Okay, so that is osseous or bony structures. Then extra-articular structures may be tendinous structures, synovium. So synovium, as you know, it is attached the periphery rim of the tibia, superior rim of the tibia, and also at the level of the attachment in the femur, at the level of the attachment origin of the articularis genu muscle, all around the articularis genu muscle, it is attached. That is synovium. So the synovium and the capsule. So a synovium is very intimately, closely attached with the capsule of the knee joint. That is the knee joint. And tendinous structures are there, that we will discuss again. Then collateral ligaments. Collateral ligaments are medial collateral ligament, lateral collateral ligament, and also medially there is oblique ligament, oblique popliteal ligament, and laterally arcuate ligament complex, and so these are all the ligaments around the knee joint. And then other ligaments, meniscofemoral ligaments are coronary ligaments are all there, and the musculotendinous units that spreads over the joint are quadriceps. So the anterior portion, middle and anterior portion is by the anterior portion, and then vastus lateralis and the lateral aspect, and vastus medialis and the medial aspect, and vastus intermedius, that is very deep. And these four muscles, four heads together, they are attached in the patella, and the patella tendon is formed in the inferior pole of the patella, and it attaches to the tibial tubercle. It attached to the tibial tubercle. And medial and lateral hamstring, that is the posterior aspect of the knee joint. Medially there are several muscles. The semimembranosus is very important muscle. Then the other muscles are semitendinosus and sartorius, gracilis. So these are the muscles and the medial aspect. So medial hamstring and the lateral hamstring are the biceps muscle. Biceps, the powerful biceps muscle is the lateral and the lateral aspect. And gastrocnemius, two heads of the medial head and the lateral head of gastrocnemius, that forms the floor of the popliteal fossa. And again on the lateral aspect there is a popliteus muscle, popliteal muscle. And these muscles and all these things are well covered and contained by the IT band on the lateral aspect. IT band on the lateral aspect, it is a deep fascia, that is a thickened deep fascia, and that is attached and the Gerdy's tubercle in the tibia, Gerdy's tubercle in the tibia. And medially these tendons, gracilis, sartorius and semitendinosus, they form and attached and the anteromedial aspect of the chin of the tibia and the medial aspect, that is called a pes ansarinus. So it is like the leg of the ansarinus pad. So that insertion is called pes ansarinus. Okay, these are all some anatomical aspect. And the ligament structures are one the joint capsule and the other is the collateral ligaments. Collateral ligaments and collateral ligaments means medial collateral ligaments and lateral collateral ligament. And medial quadriceps, not quadriceps complex, I am sorry, it is quadruple complex. Medial quadruple complex, that is apart from the medial collateral ligament, there is a medial aspect of the capsule of the knee joint. Medial aspect of the capsule of the knee joint and semimembranosus, and also posterior oblique ligament, POL, posterior oblique ligament. These are all the four structures on the posteromedial aspect of the knee joint. So that's why it is medial quadruple complex. And then another is the lateral quadruple complex. Lateral quadruple complex is nothing but the biceps muscle, the biceps femoris, and the arcuate ligament complex, and the posterior posterolateral aspect of the knee joint with the capsule, posterolateral aspect of the knee joint with the capsule, and the popliteus muscle and popliteal muscle. So that comprises the lateral quadriceps complex. Okay. Then anteromedial and anterolateral. So anteromedially actually there is a vastus medialis tendon that spreads as a retinaculum, anteromedial retinaculum, and that again blends with the medial quadruple complex. And like that the anterolateral, so vastus lateralis, they span as a lateral retinaculum, and it also attached with the lateral aspect of the iliotibial band and also the other posterolateral aspect of the capsule of the knee joint. So that is the ligamentous structures. And medial and lateral meniscus we not, but the anterior cruciate ligament and posterior cruciate ligament. Actually anterior cruciate ligament is from the prominence, tibial prominence. So that is from the anterior to the tibial prominence to the medial aspect of the lateral femoral condyle. It is from the tibial prominence, anterior aspect of the tibial prominence to the medial aspect of the inner aspect of the lateral femoral condyle, and the posterior cruciate ligament is in the posterior to the tibial prominence, in the posterior aspect of the tibial plateau, and it goes to the lateral aspect of the or inner aspect of the medial femoral condyle and medial femoral condyle. That is the because these are all very important stabilizers, especially secondary stabilizers of the knee. Okay, then Usually the etiology I already told you, football, ice hockey, kabaddi, like that. That is the etiology for the ligamentous injury. And the mechanism of injury may be divided into 4 groups. That is, one is abduction, flexion, and internal rotation on the femur on tibia. So that is one of the mechanisms to produce injuries. And then other mechanism is the adduction, flexion, and external rotation of the femur on the tibia. That is adduction. So one is abduction, second is adduction, and flexion is a very common denominator. And there in abduction, in the internal rotation, the injury may occur. Like that, that is on the medial aspect. Like that, the adduction injury, adduction and flexion and external injury may, external rotation injury may occur in the lateral aspect. Like that, hyperextension injury, so that is the tibia goes posterior and hyperextended, and again it may produce anterior cruciate ligament rupture. Like that, anteroposterior displacement, that is sideward, AP, anteroposterior displacement. And so in this, actually, if adduction, flexion and internal rotation occurs, usually the medial collateral ligament will go up. Medial collateral ligament will go up. If further force is dissipated into the joint, then it may affect the meniscus. It may affect the meniscus and also the anterior cruciate ligament. So sometimes with meniscus or without meniscus, but it may affect the anterior cruciate ligament. Still the force is continued, then it may affect the posterior cruciate ligament also. It may affect the posterior cruciate ligament. But the commonest structures that affect in the knee joint in abduction, flexion and internal rotation, because that is in kabaddi and that is the commonest mechanism of injury in the knee joint. In that, the injury to the MCL, medial collateral ligament, and injury to the meniscus, and injury to the anterior cruciate ligament is called unhappy trade of Wodanak. Unhappy trade of Wodanak. This is a spelling mistake. O, then Donax, Wodanak. So that is the name trade. So that is because it is a very commonest injury. So that is an unhappy trade of Wodanak. Okay. Then the usually, as you know, any ligamentous injury is called colloquially or generally called as sprain. So sprain, actually sprain can be graded. There is a sprain can be graded according to that injury. So usually it is a elastic fiber. Usually it is elastic fiber. Suppose the elasticity is stretched only for about half centimeter, 0.5 centimeter, then it is grade 1 injury. But it is incomplete. And if the stretching or elongation is about from half centimeter to 1 centimeter, then it is grade 2. It is grade 2. And grade 3 is more than 1 centimeter. Of course, grade 3 is maybe complete rupture. So more than 1 centimeter is grade 3. So that is one of the classifications of the sprain or ligamentous injury. And the other classification of ligamentous injury may be rotatory instability. So on rotation, it may produce instability in the knee joint because of the twist, because of the damage to the soft tissue structures and the ligaments in the joint. The instability may occur, and that instability is called rotatory instability, and it may be one plane instability, or it may be anteromedial instability, or it may be anterolateral instability, or it may be posterolateral rotatory instability, or it may be posteromedial rotatory instability, or it may be combination of these, any of these two. So one plane instability means on medial side, if it is only one plane, then the MCL is more vulnerable for injury. Like that, on the lateral side, it occurs then it is a lateral collateral ligament, injury to the lateral collateral ligament. Like that, on one plane, if on the posterior displacement alone, then it may produce anterior cruciate ligament and also posterior cruciate ligament rupture. Like that, the anterior displacement, again the anterior displacement may produce again posterior cruciate ligament injury and anterior cruciate ligament. Okay, and the combined rotator instability may be either anterolateral and anteromedial rotator instability, or anterolateral and posterolateral rotator instability, or anteromedial and posteromedial rotatory instabilities. So these are all some of the combination of rotary instability. Then actually ligaments, usually it will take 10 to 20 days to heal, especially grade 1 and 2. Grade 1 and 2 injuries. That is only elongation, just it is not a complete rupture. So partial or complete rupture of any ligament is sprain. So here the incomplete rupture or only elongation may require only 10 to 20 days for its healing. But suppose if it is grade 3, sometimes it may take a year to heal. So that is different. But the factors influencing the healing may be the anatomical location. Say, suppose in medial collateral ligament injury, suppose if it occurs in the femoral end of the attachment or tibial end of the attachment, the healing will be very slow and very minimal. Whereas in the mid substance, if there is rupture, that healing will be faster. Like that, the associated injuries. When there is associated injuries, the healing may be delayed because of more severe injury. Like that, selected treatment modalities also. So usually these injuries, not the MCL usually requires only conservative line of management, but other structures when operated, it may heal very fast. So that is the selected treatment of modalities, and various systemic and local factors like suppose any diabetes or hypertension and also other vascularly compromised diseases, healing may be slow. Like that, the smoking and alcohol, everything may contribute to the slow healing of the any structure, so also the ligaments. And grade 3 injury may take years to heal. Okay, and the healing, the ligament, like bone, the process of healing here, the healing process is also 4 phases. That is hemorrhage. Initially, soon after the injury, there may be hemorrhage around the injured area, and that injured area, the hemorrhage, then it produces inflammation, and that inflammation helps to repair. So repair of the next phase is the repair, and the last phase of healing of the ligament is the remodeling. Last phase of repair is remodeling, and the basic thing in this healing processes may be histological and biochemical and biomechanical. Okay, and diagnosis may be usually the clinical findings. So bedside medicine is very, very important. So nothing can supersede this bedside medicine. So the clinical examination is very, very important, especially history and physical findings. We should do, especially the standard stress test, that is abduction stress test, that is valgus. So with 30 degree or with full extended knee, we should give stress on the lateral aspect and the foot and the towards away from the median plane. So that is abduction thrust test. Then adduction thrust test is keeping the hand on the medial aspect of the knee joint and pushing the foot towards the median plane. That is adduction thrust test. So because in this test either medial collateral ligament in abduction thrust test, if medial collateral ligament is ruptured, it may be opened, the knee joint may be opened on the medial side. Like that adduction test, when there is failure in the lateral collateral ligament, it opens on the lateral side. Like that the rotatory tests are Slocum anterior rotator dryas test, Slocum's test, and that is with valgus stress and keeping the knee in 30-degree flexion and external rotation, internal rotation, valgus stress is applied, and in 90-degree also it is applied. Like that, again it can be done with external flexion and external rotation. These rotatory dryas test could be done, and by that we can infer or diagnose the medial collateral ligament or other anteromedial or anterolateral instability. Like that, jerk test of Houston and Brucey. So that jerk test of that is the knee is flexion and externally rotated, and externally rotating the foot, and varus stress is applied, and there is a giving way, and then other tests are lateral pivot shift test. So pivot shift test of McIntosh, that is the test where again it is a 30-degree flex and internally rotated, and valgus or varus stress is applied and slowly it is extended. So there is giving way on the medial aspect or on the lateral aspect. Like that, the dial test where the knee is fully extended and the leg alone and keeping the one hand in the lower end of the thigh, rotating the foot externally and internally, and it should be compared with the other thing. And if that rotation is the difference is more than 10-degree or 15-degree to the contralateral limb, then there is giving way of medial or lateral structures in the knee joint. Like that, other posterior dryas test, anterior dryas test, and Apley's grinding test, all are very simple tests that you know. And these tests should be done for the ligamentous injuries, especially the meniscal injury and the anterior cruciate ligament and the posterior cruciate ligament injuries. And other investigations, especially radiographic investigation, MRI and USG. So nowadays only we are doing ultrasonogram, and before that the gold standard investigation is radiographic investigation. Of course, the soft tissue structure could not be seen in the radiograph, but at the same time we can view the giving way and opening of the joint space. Suppose the global injury, that is all around the joint, knee joint is injured, definitely there may be widening of the joint space. Like that, suppose with some stress, medial stress or lateral stress, if we take X-ray, accordingly it may be with valgus stress, the medial joint may be open. Like that, with varus stress, lateral joint may be opened in X-ray, and that is joint space is increased, and because of that we can infer whether there is a disruption in the medial joint aspect of the joint or lateral aspect of the joint. So that is one of the important findings in X-ray. And another thing is to exclude any fracture, avulsion fracture. Actually, in anterior cruciate ligament injury, naturally there is avulsion of the tibial spine. So, by seeing the avulsion of the tibial spine or fracture in the tibial spine, we can indirectly infer there is anterior cruciate ligament rupture. Like that, medial epicondyle of the femur. If there is rupture of the fracture of the medial epicondyle of the femur, then we can infer there is some problem in the medial collateral ligament. Like that, the lateral epicondyle. So, these are all some of the indirect findings to diagnose directly the ligamentous injuries. Then MRI is also a gold standard investigation, very, very important investigation. But MRI is taken only after few days, 1 or 2 weeks. It is better to take 2 weeks because initially there is a severe hematoma, and that hematoma, if there is a severe hematoma, that should be aspirated, and in the aspiration itself we can find whether there is fracture or not, like that. And USG also very, very important. With that we can find some other ruptures in the ligaments, okay. And the treatment may be conservative line of management, that is non-operative management and operative management. Especially the medial collateral ligament requires only conservative line of management, that is brace. So even before that, as a prophylaxis, they advise prophylactic knee braces, BKP, prophylactic knee braces. But that is in Western countries, players they used to apply. But after injury, medial collateral ligament injury, we can apply brace for 4 to 6 weeks, and after that, after movement and passive and active movements, again it may be applied for another 6 weeks. So that is the conservative line of management. No surgery is required, and other ligaments, either suppose combined medial collateral ligament and ACL rupture, then MCL can be treated conservatively, but ACL should be repaired. ACL should be repaired either with other grafts like semitendinosis graft or patellar bone grafts or other graceless grafts can be applied. And like that, so that is an medial aspect. Like that, the reconstruction of the posteromedial corner, that is the semimembranosis and the capsule of the knee joint and posterior oblique ligament, everything should be repaired on the medial side. Like that, and the lateral side, the lateral collateral ligament alone is ruptured, then it should be also repaired. It is very easy to repair. Or suppose it is in a chronic cases, we can take other pedicles from the biceps tendon can be used, or iliotibial band, and the lateral aspect, iliotibial band can be used. So that is for the posterolateral instability, that is at the posterolateral corner of the knee joint. Okay, so even though it is very simple as it seems with the X-rays and MRI, but these problems are very critical problems. Actually, when it is not addressed properly in time, then the knee joint may go for wobbling, and it may go for instability, and day-to-day daily activities may be hampered. It is very difficult and devastating. Catastrophic problems may occur. Like so, ligamentous injuries are very, very important. Knee joint, especially knee joint injuries are very, very important for stability and for better walking. And so, even though because of running short of time, I am very sorry to discuss these things elaborately. But anyhow, up to you, it is enough. And with this, I may close this session. And thank you very much. And wish you a corona-free stay in your home. And wish you